Hello friends, as we are into Navratri, my blessing to all of you. And at the outset, I would like to thank all my subscribers and viewers from the bottom of my heart to have close to 2000 subscriptions in about 10 days. And I am so overwhelmed by your love and affection, and I will urge you to continue the same in future. I assure to come out with more and more informative videos which will uplift your knowledge, and I will see to it that I will give the best possible output through my videos. Thank you once again. Today's video is on which IV fluids in septic shock, and I'm sure this is a topic which is quite intriguing, and it can be a dilemma for all we intensivists practicing in ICU as a critical care specialist. This was the talk which I delivered in the month of November 2023 during the conference on controversies in pulmonary and critical care at Zydus Hospital, Ahmedabad. So let's start with the topic. At the outset, I would like to ask me a question: why IV fluids? As we know that history is an integral part, and let us just ponder upon few historical perspectives as far as fluid therapy is concerned. In 1830, during the cholera pandemic, as it was known during that time that the blood becomes thick and the IV fluids were used. In 1880, Dr. Sidney Ringer used IV fluids in surgery and post-operative period, and now famously we know the fluid as Ringer lactate. In 1899, George Washington Cryle used warm Ringer lactate, and of course in 1930, Alexis Hartmann used sodium lactate at the famous Hartmann solution as we know today. And eventually when we come down to the recent Shoemaker and colleagues, which use the concept of supranormal resuscitation in goal directed fluid therapy to improve the cardiorespiratory function. So as we know, sepsis starts as inflammatory cascade with upregulation of pro-inflammatory cytokines like TNF alpha, interleukin 1, interleukin 6, followed by endothelial damage and followed by capillary leak, which is predominantly due to the endothelial dysfunction, which leads to microcirculatory failure and eventually the organ failure. So the capillary leakage syndrome, which is a frequent complication in sepsis and inflammation, is typically characterized by loss of intravascular fluid, generalized edema and hemodynamic instability despite the fluid therapy. Talking about the Surviving Sepsis Campaign guideline as the evidence supporting the fluid therapy in septic shock, which were published last in 2021, which recommends the immediate crystalloid resuscitation in sepsis-induced hypoperfusion or septic shock patients. The crystalloid bolus at a dose of 30 ml per kg within the first 3 hours of resuscitation, and this is something which is followed globally by our intensivist colleagues. Monitoring of lactates which is recommended, and these are the weak recommendation and low quality evidence. So there could be inter-individual variations as far as the fluid therapy is concerned for the resuscitation, which can have an impact on the outcomes. As far as surviving sepsis campaign guidelines are concerned, the targets which were postulated were the mean arterial pressure of more than 65 with CVP of 8 to 12, urine output target of more than or equal to 0.5 ml per kg per hour, the mixed venous oxygen saturation between 65 to 70% with normal lactates. This can be disputed, but by and large at this point in time, if I have to give the message, these are the targets on which we should work as far as resuscitation with crystalloids are concerned in septic shock patients. There were three major trials which were published in NEJM: the Process, Arise and Promise, which talked about the goal-directed resuscitation for septic shock patients. Those who did not receive the fluids had increased in the risk of mortality, delayed reversal of hypotension and prolonged ICU stay. This was a retrospective analysis which was published in Critical Care Medicine 2019. So here there is an emphasis, of course, on usage of crystalloid solutions for resuscitation of septic shock patients. And as any patient, we have assessment which is ongoing and the evaluation which keeps on happening on hour to hour, minute to minute basis. So ongoing assessment and re-evaluation is very vital, and I will emphasize upon this fact that as an intensivist, ongoing assessment and re-evaluation forms the cornerstone for the success of any critically ill patient. So the initial fluid resuscitation followed by continued fluids, looking for any signs of fluid overload, whether the patient needs prolonged ventilation with a risk of AKI, and of course the mortality. So these are the parameters on which the assessment will depend upon. So for adults with sepsis or septic shock, we suggest using dynamic measures to guide fluid resuscitation over physical examination or static parameters alone. So this was a weak recommendation and very low quality evidence, again mentioned or published in Surviving Sepsis Campaign guideline. And what are the dynamic parameters what we are looking at? These are predominantly the stroke volume variations, the pulse pressure variations, the echocardiography wherever it is available. This is a very recent paper in 2024 which talks about the fluid management in the septic perioperative patient, and as you could see that it recommends a personalized fluid resuscitation anywhere between 10 to 20 ml per kg ideal body weight. So as I am talking to you now, the Surviving Sepsis Campaign guideline would be shortly published, focusing mainly on the individualized crystalloid fluid bolus approach, and the dose which they have kind of used and found to be effective would be less than 30 ml per kg, maybe to the tune of 20 ml or even 10 ml per kg. So which IV fluid would be ideal? It is the one with more physiological resemblance with our plasma, with less toxicity, less expensive, easily available. It should be more balanced with a desired response. And as we know in this world, nothing is ideal. But can we target or achieve the ideal fluid which is close to IV ideal fluid? We'll see. So the same fluids would have strong ion difference, the osmolarity which is close to plasma. It should exert oncotic pressure which is again close to the plasma, and have less endothelial glycocalyx damage. There's something called a strong ion difference, which is nothing but the difference between strong cations and the strong anions, and the value is between 40 to 42 milliequivalents per liter. As you could see, the SID of normal saline is 0 milliequivalents per liter. So it is actually a misnomer, and it is not a normal saline. It is actually an abnormal saline. And the reasons are quite evident, which are in front of you. SID of RL, which is 24 milliequivalents per liter, and SID of a plasma light or a balanced crystalloid, which is 47 milliequivalents per liter, which is fairly close to a physiological fluid with SID of 40 to 42. So at this point in time, we can say that the physiological fluid or a balanced crystalloid solution which has SID which is close to the plasma solution, the SID of a plasma solution. The fluids which are not preferred, and this is a very clear and emphatic message which I need to give it today, is at this point in time in the present day critical care practice, the use of synthetic colloids has almost come to an halt, and we rarely use hydroxyethyl starches or gelofuscin or gelatins or dextrans for that matter in a very less percentage of patients or very less number of patients. The physiological colloids like blood and even the physiological colloid which is close to plasma, the albumin, these are the two colloids at this point in time which are used in the critical care practice. The colloids which are not used are for obvious reasons. The albumin and the starches which we actually are talking about. So starches predominantly are prone to cause allergic reactions, the renal dysfunctions, the coagulopathies. So these are the predominant reason why colloids are not being used in ICUs the way they were used before. Now, this slide speaks of the difference between colloid and crystalloid. So colloid, as we know, that it has a high plasma volume with less propensity to cause peripheral edema. It needs smaller volumes for resuscitation and the intravascular half-life of between 3 to 6 hours. Whereas crystalloids, they are less expensive. They are used for maintenance fluid and inertial resuscitations. They restore the third space loss, and the intravascular half-life is anywhere between 20 to 30 minutes. So these are the differences which needs to be remembered. As I said, albumin, which is typically indicated following large volume paracentesis in patients with liver cirrhosis for extracorporeal albumin dialysis, after liver transplantations, and of course hepatorenal syndrome. So these are the indications which we may say at the modern use of albumin, the indications which are to be used in ICU. Now talking about the SAFE study which got published in NEJM way back in 2012, which compared saline versus albumin fluid evaluation, and it actually compared the effects of these two resuscitative fluids in terms of 28-day all-cause mortality. And the conclusions were that they had a similar mortality, similar time to death in those who died, similar use of mechanical ventilation and renal replacement therapy, similar incidence of new organ failures, and similar ICU and hospital length of stay. So there was hardly any difference. So someone who is preferring albumin over saline may not be a very good strategy. Talking about this Myberg et al. Trial published in NEJM in 2012, which compared hydroxyethyl starch with normal saline, and the final recommendation which came out was the colloids which increased the risk of AKI, and actually it was suggested not to be used. talking about the albumin trial, which compared 20% albumin with crystalloids, and as you could see that in the group of albumin and crystalloid, the MAP was higher, the fluid balance was lower, the mortality, if you could see that they are actually similar, and again there was no difference in the incidence of AKI. So this was the same Myberg trial which I was talking to you about, where the colloids will increase the risk of AKI, and the post hoc analysis which showed in TBI patients 24 months mortality was in fact higher in albumin group. So it is no wise decision to use albumin in TBI patients. There were other three big trials which compared hydroxyethyl starches with crystalloids, namely the CHEST trial, YSEP trial, and 6S trial. We're trying to look here, which is obviously or evidently not seen. And just a bit on crystalloids, as we know that the isotonic solutions like 0.9% saline or a normal saline with osmolarity of 300 milliosmoles per liter, and the hypotonic saline or the hypotonic solutions which will decrease the osmolarity, and it may increase the cerebral edema and the increase in the intracerebral pressure. So this is one clinical entity where I would be little skeptical about using the hypotonic or balanced crystalloid solutions in these cases, especially in the TBI patients. But by and large, they are the ideal IV fluids over normal saline. And as we know that normal saline is a misnomer, it is actually an abnormal saline. So just a glimpse upon the various IV fluids, and as you could see that these IV fluids in the box, the ringer lactates, the plasmalite and stereofundin, as you could see that the plasmalite and the stereofundin are the examples of the balanced crystalloid solutions, and the sodium in these particular fluids are lesser than that of plasma, potassium which is to the tune of 4 to 5, chlorides which are less as compared to that of normal saline. You could see that there is acetate in them as a buffer solution and malate in stereofundin as a buffer solution. So this will give you a good snapshot as a comparative compositions of different IV fluids. And as we know, SID of normal saline is 0, which is not good. So normal saline will do a lot of harm, and these are few of the adverse effects of normal saline. So it will cause high, hyperchloremic metabolic acidosis. It will have impact on the glycocalyx in the form of the damaging the glycocalyceal system. It will have GI edema. It will increase the intraoperative blood loss. It will have more complications, and thus it may contribute to high mortality in most of the patients where it is used as a high volume. And of course we cannot forget the renal derangements in the form of AKI and even the requirement of renal replacement therapies for those who receive high volume normal saline. So we have to be very, very careful. So talking about chloride rich crystalloids, which is clearly they can cause AKI due to hyperchloremic metabolic acidosis, and there is obviously a concern of hyperkalemia. So these were the 4 observational studies, and which showed that the balanced salt solution were superior as compared to normal saline in having less incidence of AKI and less mortality. So thus in septic patients or septic shock patients, the use of balanced solution may improve the survival, which will be independent of the severity of the illness and the volume used. But this will give us a lot of confidence to advocate use of balanced crystalloid salt solutions, especially in the patients with septic shock. Now this was a split randomized clinical trial, again comparing normal saline and buffered crystalloid or the balanced crystalloid which was published in JAMA 2015, and the conclusion was with the use of balanced crystalloid, the risk of AKI has come down. So definitely there would be some benefit, if not a direct mortality benefit, in the use of balanced crystalloid salt solution to decrease the risk of AKI. So this was another study which was published in JAMA in 2021, which compared the balanced crystalloids with normal saline, and it was shown that it will decrease the 90-day mortality. So this was again a kind of a positive study as far as use of balanced crystalloids are concerned, and we need to actually remember these studies. And this was, as I said, this was the conclusion. Of course, normal saline is safer in TBI, but apart from this particular clinical entity, majority of conditions we would get away with balanced crystalloids, and we may actually remember that we may use balanced crystalloid solutions in these particular situations. So in a non-critically ill adult patient, there was one study by the name of SALT-ED trial, and there was a conclusion that there was no difference in hospital-free days between the treatment of balanced crystalloids and normal saline, whereas the SMART trial, which showed that the use of balanced crystalloids, which resulted in the lower rate of MAKE 30 than the use of saline, and MAKE stands for major adverse kidney events. So clearly there is a message which these all the trials or studies which we just now saw, which gave some signal towards shift of our choices from normal saline towards balanced crystalloid solution in terms of decrease in the incidences of AKI. Now there are the contraindications for balanced solutions in the form of hypernatremia, hyperkalemia, renal failure, heart block, metabolic or respiratory alkalosis, hypocalcemia or hypochlorhydrimia, concomitant use of potassium sparing diuretics, and there is no adequate data of plasmalide use in pregnancy or lactating females. So if I need to have the take home message for you today, friends, as I said, colloids, if you ask me, then probably at this point in time I would say no. Albumin, yes, in some situations I may use albumin, especially for patients with sepsis or septic shock. We suggest use of albumin in patients who received large volume crystalloids, but here I have said no. The reason is that we don't advocate or use albumin as a standard of care, but in a very few subset of patients where we have large volume of crystalloids already being given to the patient, and there is the resuscitation which is not yet achieved, and we have not mitigated the risk of hyporesuscitation. There I may probably say that we can use albumin, but by and large, if I have to give you the message, it probably is no. Crystalloid is of course yes for adults with sepsis or septic shock, and this is the surviving sepsis guideline which recommends use of crystalloids as a first line fluid. Normal saline I think is a big no, since it is not a normal saline, it is actually a abnormal saline. Of course, balanced crystalloids, the balance is tilting towards its use, and again the surviving sepsis guideline recommend use of balanced crystalloid instead of normal saline for resuscitation. So this is my friend Dr. Manoj and Dr. Ritesh, and I hope you all enjoyed the teaching today, and the clear cut messages what I am trying to give. And of course I would probably recommend at this point in time the use of balanced salt solution. If there is a resource limiting situation, if the cost is a concern, if your fellow colleagues and the fellow primary consultants are concerned about the cost of the balanced crystalloid solution, then the closest fluid which I can recommend today is crystalloid in the form of ringer lactate. So my kind of regards and my prayers to this great man. And thank you so much for patient listening.